This program is brought to you by Emory University.
Good morning, everyone, and thank you for joining. It is my great pleasure to introduce one of our own, Dr. Byron Williams III, also known as Robbie. Dr. Williams started his medical career at Emory in 1997, first as a medical student, and then stayed on for internal medicine residency and chief resident here, followed by cardiology fellowship and chief cardiology fellowship at Emory. So he's been here a long time. As I mentioned, I've known Robbie for almost 20 years, more than 20 years. I have known, I can honestly say that he's a strong leader, a problem solver, always brings a positive attitude, highly invested in medical education and well-being for our house staff. He's been the program director for a cardiovascular disease fellowship program since 2013. And I don't know how he does it, but he reviews about 1,000 applicants every year, going through trying to pick some of our best fellows. He lectures regularly at the cardiology core curriculum conferences, teaching EKGs, and leads the Friday morning conferences. He's also serves as the medical director of the Emory Hypertrophic Cardiomyopathy Clinic, and I believe he implemented this clinic, which is a major referral center for us in the Southeast here, an expanding clinic that provides complex care to these complex sort of patients. He's also the assistant director of the Emory Echo Lab. He's received many awards, including Excellence in Teaching Award, Fellowship Teaching Award, the J. Willis Hurst Teaching Awards. And so without further ado, he's going to give us an update today on new frontiers in hypertrophic cardiomyopathy. Robbie.
Thank you, Pooja. Good morning, everybody. Pleasure to be speaking with you this morning on a topic that's near and dear to my heart, hypertrophic cardiomyopathy. I think the goal of this talk this morning is not necessarily to give a comprehensive overview of hypertrophic cardiomyopathy, but more just to touch on a few topics, sort of emerging areas of change in the disease that are either upon us or coming in the near future. No financial relationships to disclose, and we will be discussing the off-label use of medications during this talk. So we're going to talk a little bit about the coming drug, hopefully, the direct myosin inhibitor known as mavacamten, and its promise for what it might deliver in terms of therapeutics for this condition. Dr. Billen gave a talk on hypertrophic cardiomyopathy last year at this conference and touched on this topic. So if you tuned in for that talk, unfortunately, there's not a ton. It'll be a lot of the same stuff, but I think it's worth covering again as we hopefully get closer to this drug reaching the market. We're going to talk about a potential new technique for septal reduction therapy that was really developed in large part here at our institution. And we're going to lastly talk about the evolving concept of sudden cardiac death and sort of how we continue to change how we think about sudden cardiac death in patients with hypertrophic cardiomyopathy. So first, a definition: hypertrophic cardiomyopathy. It is a genetic disease caused by a mutation in one of several proteins of the cardiac sarcomere that results in left ventricular hypertrophy in the absence of or out of proportion to another identifiable cause, i.e. hypertension, valvular disease, et cetera. So again, LVH without an identifiable cause or really out of proportion if they do have mild hypertension, for example. The disease prevalence is approximately 1 in 500, and this has been pretty consistent almost in every region of the world. Equal prevalence amongst men and women, pretty homogeneous throughout the world's population at this point. Caused by a mutation in one of 14 known genes that encode proteins in the cardiac sarcomere. Over 90% of cases, though, result from a mutation in one of these three genes: beta myosin heavy chain, myosin binding protein C, or cardiac troponin T. The other remainder are smattering of other less commonly affected genes. And this genetic disease is passed on from one generation to the next in an autosomal dominant inheritance, which highlights the importance of cascade screening, family screening of all first-degree relatives when the diagnosis of hypertrophic cardiomyopathy is made. Here are some echocardiographic images of sort of your basic variety hypertrophic cardiomyopathy. On the left, the parasternal long axis view showing asymmetric septal hypertrophy, where your septum is noticeably more hypertrophied than the posterior wall. There are not a lot of other conditions that will cause this degree of asymmetric hypertrophy. So right away, you'd be suspicious this patient have hypertrophic cardiomyopathy. You also notice pretty clear example of systolic anterior motion of the mitral valve during systole. And the image on the left, on the right as well, same patient, looking at the apical 3 chamber view, showing again the systolic anterior motion of the mitral valve with obstruction of flow in the left ventricular outflow tract and the sort of classic posteriorly directed mitral regurgitation, which often results from this dynamic left ventricular outflow tract obstruction. You also notice systolic function, as per usual, is preserved or even hyperdynamic in these patients. Now, the majority of patients with hypertrophic cardiomyopathy, but not all, do have left ventricular outflow tract obstruction. Approximately 2/3 do. Some will have left ventricular outflow tract obstruction at rest, and some require provocation with exercise, Valsalva maneuver, theoretically amyl nitrite, which we don't really use much anymore, but really we try to provoke it with Valsalva or exercise. So between those that have obstruction at rest or those that you can provoke, roughly 2/3 of all patients with hypertrophic cardiomyopathy will have at least some degree of left ventricular outflow tract obstruction. And this tends to be the major driver of symptoms in patients that do have obstruction. So we do have medical therapy for left ventricular outflow tract obstruction. As you all know, first-line therapy is beta blockers. Verapamil can also be used to treat these patients, potentially for those that do not tolerate beta blockers. You could try verapamil as a second-line therapy. And thirdly, disopyramide is another medication that can be added on to either their beta blocker therapy or their verapamil therapy to help improve their symptoms if they're still symptomatic despite maximum tolerated dose of either beta blocker or verapamil. So disopyramide is a class 1A antiarrhythmic. It does have some negative inotropic properties thought to occur by its alteration of the sodium-calcium exchange. It does have fairly good hemodynamic data, actually superior to that of beta blocker or verapamil alone in terms of its ability to reduce left ventricular outflow tract gradients. And also is mildly helpful in controlling atrial arrhythmias. That's what it was initially designed for. It's not a terribly effective antiarrhythmic, but probably better than nothing. So might be a little added benefit in patients that may also have atrial fibrillation. Now, all these medical therapies that we have at this time, beta blockers, calcium channel blocker, verapamil, and disopyramide, none of these drugs were specifically designed for hypertrophic cardiomyopathy, and technically none are even indicated to treat hypertrophic cardiomyopathy. So these are all off-label uses of all of these drugs. That brings us to mavacamten. Mavacamten is the first drug designed specifically for hypertrophic cardiomyopathy. It is a selective inhibitor of cardiac myosin. It is a potent negative inotrope as opposed to disopyramide, which is a mild negative inotrope. Mavacamten is, at least on paper, a much more potent negative inotrope than disopyramide. Unfortunately, it is not yet approved by the FDA. There is another date in late April where they are supposed to review the drug again and potentially approve it, but that was supposed to happen back in December and got delayed to April. So we'll see, it may get delayed again. So go back to remember your components of the sarcomere. If you look up on this figure up in the top left image here, you have the myosin thick filament and the actin thin filament in the cardiac sarcomere. You also have these cross-bridging proteins that link the actin and the myosin. So this is what it looks like in a normal cardiac sarcomere. The middle image shows what hypertrophic cardiomyopathy looks like. So part of the pathophysiology of this condition is upregulation of these actin myosin cross-bridging proteins. And this results in hypercontractility, difficulties with diastolic function, and altered myocardial energetics, which can lead to premature cell death, et cetera. So what mavacamten does, it directly inhibits these cross-bridging proteins and tries to return the cardiac sarcomere to a more normal appearing state, as you'll see in the top right image, where you do not have the same degree of cross-linking between the actin and myosin filaments, which will hopefully, in addition to creating some negative inotropy, but will also improve diastolic function and hopefully return the energetics of the cell back to a more normal state. So the first trial that came out for hypertrophic cardiomyopathy back in 2020 was the Explore HCM trial, a randomized double-blind placebo-controlled trial looking at mavacamten versus placebo for patients with known obstructive hypertrophic cardiomyopathy. This study was overall a success. This busy slide showing, these are a lot of the secondary endpoints. We'll look at these first. So the top left table shows the post-exercise left ventricular outflow tract gradients at the onset of the trial, and then at the end of the trial, which was 30 months later. And as you can see, the post-exercise gradients declined significantly over the course of the trial. Top right shows ejection fraction, which you saw a slight decline in ejection fraction, 4 or 5 points on average. If you'll notice, most of these patients started with an ejection fraction. The average ejection fraction was in the 70s for these patients and declined to about 70 by the end of the trial. The resting left ventricular outflow tract gradients also declined significantly over the course of the treatment, and the Valsalva LVOT gradients declined significantly as well. They looked at biomarkers as well in the study group and the control group, and as you can see, pro-BNP levels declined significantly over the course of the study. From onset of treatment to the end of the treatment. Sorry, I said 30 months earlier, it's like 30 weeks to the end of the trial. And the troponin levels declined significantly as well after about, looks at about 18 weeks, that became significant. So significant decrease in not just measured gradients, but cardiac biomarkers as well. The primary endpoint was improvement in symptoms, defined as improvement in peak VO2 of 1.5 mLs per kilogram per meter squared or more, and an improvement in New York Heart Association class of at least one class. And this is looking at the different subgroups. Again, a busy slide, but shows that for the majority of the subgroups, there was significant improvement in the primary endpoint, i.e. symptoms. And in those that weren't significant, there was a trend towards improvement with mavacamten. Altogether, it did meet statistical significance for improvement in symptoms overall. Now, a follow-up study to this was the Explore HCM CMR sub-study, where they looked at cardiac MRI criteria for those being treated with mavacamten. And what the MRI data did show is favorable remodeling in the mavacamten group compared to the placebo group. The LV mass index decreased by 15.8 grams per meter squared in the treatment group compared to control. The max wall thickness decreased by an average of 2.8 millimeters. The left atrial volume index increased by 10.3 mLs per meter squared. There was no change in the amount of delayed gadolinium enhancement, notably between the control group and the treatment group. And the ejection fraction, as we saw from the echo data in the Explore HCM, the ejection fraction decreased by 6.4% on average in those treated with mavacamten. So as we saw in Explore HCM, not only an improvement in symptoms and improvement in biomarkers, but significant reduction in gradients. And this is actually maybe even more exciting because, you can get decent to good improvement in symptoms with our current medical therapy. And certainly you can get reduction in gradients with our current medical therapy, but we've certainly never seen anything like this with beta blocker or verapamil or disopyramide. So this is actual changes in the phenotype, regression, if you will, of the phenotype with this medication mavacamten. So this is actually fairly exciting development. So what about non-obstructive? So all that data from Explore was in patients with known obstructions. What about our non-obstructive group of patients, which, in my experience is actually, in a lot of ways, can be a more difficult group of patients to treat just because we simply don't have the number of options to provide to the patients for non-obstructive. So for non-obstructive patients, we don't have a ton yet. This was the Maverick trial. So this was actually just a small exploratory trial, really just designed to assess safety and tolerability, not necessarily powered to assess efficacy. So it was a small trial where they had 3 groups with only about 20 patients in each group. They had a control group, a low dose group, and a high dose group. This table on the left shows biomarkers, showed a non-significant decrease in proBNP levels. In the treatment groups, you have the control dash line, and the red and blue lines are low and high dose treatment groups. So you saw a non-significant decrease in proBNP levels and a non-significant decrease in troponin levels in the treatment group. And the table on the right is essentially summarizing their symptomatic improvement, which again, non-statistically significant. But again, this was not powered to necessarily detect differences in these outcomes at this time, and further investigation is ongoing. But the drug did seem to be safe and well tolerated. I believe one patient had to be stopped, had to drop out of the trial because their ejection fraction fell below 50%. So the initial data with mavacamten is encouraging. There's more to come. The Valor HCM trial is ongoing. This is looking at mavacamten versus placebo, again, in obstructive patients eligible for septal reduction therapy. So you'll get randomized to mavacamten versus usual care, which could include septal reduction therapy. And that's scheduled to be completed here soon in terms of data collection. So we'll be interested to see how that turns out. There's ongoing trials looking at non-obstructive patients. Now, the concerns are this drop in ejection fraction that we saw, 5-point roughly drop in ejection fraction in patients. Will this, continue to worsen over time? We have relatively short study windows for these trials. If you recall, this is the data from Explore, where we saw the curves separate in terms of ejection fraction at, 12, starting to separate early. And then by about 12 weeks, they've clearly separated. Now, it doesn't appear that they're continuing to separate as time goes on, but who knows? If you continue to study this drug over longer periods of time, does the patient's ejection fraction continue to decline? We'll just have to wait and see. But it is exciting, not just for the symptom improvement that seems to be robust and the LVOT gradient reduction, which seems to be robust, but the ability to alter the phenotype. And then, future efforts to look at, giving this drug to patients with newly discovered, maybe early stage HCM, or even possibly the genotype positive, phenotype negative individuals. And does this alter the course of the disease? Something we've never really been able to do, which is almost every patient who we diagnose with HCM or we find as gene positive, their first question is, well, what can I do to, alter the course of this disease? Can I do anything to keep this from getting worse or whatever? And the answer is always, unfortunately, no. We just have to sort of wait and see how this thing plays out. So it would be potentially exciting to have something to offer in that regard. So that's mavacamten. So, for those with left ventricular outflow tract obstruction that we have tried on medical therapy and they're still symptomatic despite our best efforts with beta blocker or verapamil, possibly plus disopyramide, we've had the option for years of septal reduction therapy, both surgical myectomy, which was first described in 1961 by Dr. Glenn Morrow at the NIH, as well as alcohol septal ablation, first described in 1994 by Dr. Sigwart. Both very effective means of, but invasive means of reducing left ventricular outflow tract obstruction, improving symptoms, and reducing the risk of future events such as heart failure. As I mentioned, surgical myectomies now have been around for over 60 years, low mortality, surgical mortality rates, very effective at reducing gradient and symptoms, relatively low complication rate, small risk of heart block, small risk of VSD. Alcohol septal ablation, we're now over 25 years into our experience with this. Again, very low mortality rate, very quick and easy recovery for the patients. Again, very effective at reducing gradient and symptoms. A higher rate of complete heart block compared to surgery, but otherwise very low complication rate there as well. So two very good, very effective treatments for left ventricular outflow tract obstruction for patients that are still symptomatic despite maximal medical therapy. And these now have been around for years and are well studied. However, recently a new procedure has come about known as the SESAME, septal scoring along midline endocardium, is where the name comes from. The SESAME procedure was developed in large part by our structural team here at Emory in conjunction with Dr. Robert Lederman at NIH, where essentially you use a wire that you pass through the myocardium of the septum and then electrify it and create a trough in the ventricular septum percutaneously. So here is a video provided by our structural team. That's the view through the aortic valve. You'll see that's to have two catheters, that one you place up against the basal edge of the septum. One will go down into the left ventricular cavity. You'll see a wire is passed directly into the septal myocardium and is advanced through the septum. Eventually, they will make their way out into the left ventricular cavity where the wire is snared. They will then pass current through the wire and retract. I've asked if they had to put their foot up on the table to do this. They don't, but they pull back on the electrified wire and it creates this scoring or trough in the interventricular septum. So here are some cardiac CT images provided again by our structural colleagues. On the left is pre-sesame, and on the right is post-procedure day 1. So what you'll see is this trough that's been created here in the sort of basal to mid septum, and then the short axis view, again, you get this sort of, again, this channel that's been cut in the interventricular septum. Here was a patient of mine that was referred, or a patient of ours that we referred to the structural team a couple weeks ago for this procedure. Here was her baseline TEE, which showed significant turbulence, left ventricular outflow tract obstruction, as well as significant mitral regurgitation pre-procedure. Here is an image with the 2 catheters. Here's the catheter that goes down to the left ventricle they use to snare. There's a second catheter you can sort of see there with the wire coursing through the left ventricle. At this point, they're snaring the wire as it comes out in the left ventricular cavity. This is a post-procedure image, which shows this trough that they have made in the interventricular septum with the wire. And here is the hemodynamic data, both pre and post, from this patient. Pre-procedure, about a 50 millimeter peak-to-peak gradient, and essentially no gradient at the end of the procedure. So our structural team's experience to this point, again, I've been told this has been done a few times at a few other centers, but the majority of the experience really in the world with this procedure is at our institution. They've now performed this procedure on 14 patients, either for hypertrophic cardiomyopathy or with patients undergoing transcutaneous mitral valve replacement to widen the left ventricular outflow tract. Because, if you deploy a percutaneous mitral valve, that anterior mitral leaflet can get pushed into the left ventricular outflow tract and cause inadvertent left ventricular outflow tract obstruction. So they've done it for either of those indications. They've had 2 in-hospital deaths, so although neither were felt to be related to the myotomy itself, more due to other sort of valvular causes or heart failure, et cetera. 1 patient of the 14 developed heart block post-procedure requiring pacemaker replacement, although it was noted that their heart block resolved after a couple days. There have been no ventricular septal defects or other untoward events. The gradient reduction has been robust, ranging from 38 millimeters of mercury to 129 millimeters of mercury. And one advantage of this procedure is, unlike alcohol septal ablation, you are not dependent on the variants of coronary anatomy, septal perforator anatomy, which is one of the drawbacks potentially of alcohol septal ablation. So again, a promising, very early in development procedure that may offer an alternative to septal reduction, in addition to the 2 tried and true procedures that we've had now for several years. So last, I want to talk about sudden cardiac death or cardiac arrest in these patients, and sort of how our notion of that has evolved through the years. So early on in the understanding of this disease, now over 50 years ago, in the 1960s, the early estimates of sudden cardiac death in these patients with hypertrophic cardiomyopathy were as high as 6% annually. Time would show that this was an overestimation, probably due to referral bias and just the early databases consisting of very sick patients being referred to NIH. Even as not too far back, when I first, started treating patients with this disease and giving talks on it, the incidence of sudden cardiac death was quoted as closer to 1% annually. That's even come down in the last decade or so. The incidence of sudden cardiac death is now thought to be approximately 0.5% annually in these patients. Certainly higher than the general population, which is somewhere slightly less than 0.1%, but not exorbitantly higher as initially thought. Although our understanding that the risk of sudden cardiac death is not as high as we once thought it was, there's clearly a subset of patients that are at increased risk of sudden cardiac death. And as providers, that's one of our most important roles when we take care of these patients, is identify those patients that are at increased risk. And our tools for doing this are getting better all the time, but still not perfect. So this is a slide that I've shown for years. This was sort of, again, when I first started giving talks on this, this was sort of the slide that we would show, that how we would think about patients and their risk of sudden cardiac death. And there were these 8 risk factors that we knew of: history of prior cardiac arrest, documented sustained VT, family history of sudden cardiac death due to hypertrophic cardiomyopathy in a first-degree family member, episodes of unexplained syncope, severe or extreme wall thickness defined as greater than or equal to 30 millimeters, documented the episode, more than one episode of non-sustained VT in 24 hours on ambulatory monitoring, drop in blood pressure with exercise, or extensive delayed enhancement on cardiac MRI. Those are the 8 risk factors, sort of more or less all weighted equally, except for really the top 2. We knew that the top 2 risk factors, the history of cardiac arrest or sustained VT, carried more weight, but the rest of them were more or less treated equally. And any one of these could be seen as a potential indication for ICD therapy. Well, the most recent set of guidelines, which came out back in 2020 for hypertrophic cardiomyopathy, address this. And they stress that the one thing that they stress is that the assessment for risk of sudden cardiac death is an ongoing process that should continue throughout the course of care for these patients, approximately every 1 to 2 years, and should include an assessment of personal history of cardiac arrest, obviously, or sustained ventricular arrhythmias, personal history of syncope, family history in a close relative of sudden death related to hypertrophic cardiomyopathy, assessment of maximum wall thickness, ejection fraction, assessment for LV apical aneurysm, which was new, assessment for non-sustained VT on ambulatory monitoring, and strongly considering cardiac MR imaging to assess, again, maximal wall thickness, ejection fraction, looking for apical aneurysms, and extent of delayed gadolinium enhancement. So this is a more sort of modern, as opposed to that slide from a couple slides ago, this is sort of our more modern concept of cardiac arrest, sudden cardiac death, and how we think through these patients. Sort of flow chart here. So, first question is, has the patient had sudden cardiac death, aborted sudden cardiac death, or documented sustained VT? If so, then absolutely an ICD is indicated, no doubt about it, green light for an ICD, no mystery there. Second sort of group of questions, so these would be sort of stronger indications for ICD therapy, would include, again, a family history, the extreme wall thickness, more than one recent syncopal episodes, the presence of an LV apical aneurysm, which again is a relatively new indication for defibrillator therapy, or at least it had been sort of bandied about, but to put it in the guidelines is new, or reduced ejection fraction defined as ejection fraction less than 50% in these patients, as opposed to the normal cutoff of less than 35%. The cutoff for patients with hypertrophic cardiomyopathy is less than 50% that's been shown to be significantly associated with increased risk of sudden death. So any of those, family history of wall thickness, syncope, apical aneurysm, reduced EF, is a 2A indication for ICD. Non-sustained ventricular tachycardia on Holter, defined as more than one episode in a 24-hour period, or excessive delayed enhancement is a 2B indication for ICD, where it's a little more uncertain. Now, I can tell you these, again, depending on the patient's age and patient preferences, I would tend to lean towards defibrillator therapy in these patients. I saw something in the chat. It's an old question, so I guess we'll get to that at the end. Sorry, Dr. Balk, I missed that. None of those present. ICD not indicated at this point in time. Again, but recommendation is these factors get reassessed every so often. Now, I don't typically do cardiac MRIs every 1 to 2 years. That's generally a one-time thing, but I might repeat an MRI if I do see significant changes in the phenotype. So if we'd gotten an MRI maybe very early in the course of the disease, where the maximum wall thickness was 18 millimeters, and now by echo, their maximum wall thickness is very close to 30 millimeters. There's been definite changes. I might repeat an MRI again to get a very accurate measurement of max wall thickness and to reassess for the presence of delayed enhancement. We also have the European Society of Cardiology's risk calculator that they came up with back in 2014, which I will use at times, particularly for sort of a borderline patient, to help define their risk. It's a calculator, sort of an online calculator that you can look at, very similar to the ASCVD risk calculator, where you put in a series of variables, including patient's age, their maximum wall thickness, where it's not a binary less than or over 30, it's sort of more of a continuum based on their wall thickness. The left atrial size, which, the data supporting that is not great, but, they went with it. The peak LVOT gradient, which again, the data supporting that as a risk factor for sudden cardiac death is controversial, but they went with it. Family history of sudden cardiac death, non-sustained VT, and unexplained syncope. And what you get is a 5-year risk with the European calculator, and a recommendation. If their 5-year risk comes out at less than 4%, they would not recommend an ICD. If it is 4 to 6% or approximately 1% per year, they say individualize your decision. And if it comes out at greater than 6%, the calculator recommends you put an ICD in. So again, just another tool, another piece of data you can use, particularly for those patients that are maybe a little bit borderline, maybe say those that just have a little bit of non-sustained VT on Holter, or maybe just some delayed gadolinium enhancement on cardiac MRI, but everything else, it looks okay. So a couple things to highlight. So in these last set of guidelines in 2020, exercise testing as a predictor of sudden cardiac death was de-emphasized. Still recommended for assessment of patient symptoms, or to look for provocable gradients with exercise. But as a predictor of sudden cardiac death, the blood pressure response to exercise was de-emphasized as a predictor of sudden cardiac death. So what do we do with patients over the age of 60? There's emerging evidence. We've always known that cardiac arrest was more prevalent in younger patients with this condition, as opposed to most other causes of sudden cardiac death in our field that tend to go up with age. Actually, with hypertrophic cardiomyopathy, it actually tends to go down as patients get older, to the point that over the age of 60, the rate of sudden cardiac death appears to be really quite low. So what do we do with these folks over the age of 60? Do we continue to test them, assess them for their risk of cardiac death. I don't know if there's a great answer to this question. I think it's probably unwise to just totally stop screening these patients for their risk over the age of 60. Personally, I maybe am not quite as vigilant in terms of, having them wear halters and things of that nature after the age of 60. We still do it, but maybe just not quite as regularly. Maybe we space it out a little bit, et cetera. Obviously, you're still going to ask them about things like syncope and things of that nature, but we're still trying to sort through what to do with these patients once they get over the age of 60. And in the most recent guidelines, there was an emphasis on the role of shared decision-making as it relates to ICD placement, that certainly the patient and other stakeholders, family members, et cetera, should be involved in that decision-making process. And, it turns out that a lot of these patients end up with a lot of those sort of borderline, particularly the non-sustained VT and the delayed enhancement on cardiac MRI. It's very frequent that we clinically see patients who just have those sort of 2B indications. And then a lot of times it comes down to sort of what the patient's, certainly the younger the patient is, the more likely I'm going to be to refer them for defibrillator placement as opposed to an older patient. And certainly if the patient is really interested in having a defibrillator because they feel like it'll help alleviate whatever anxiety they may have about their disease, then certainly that may help in the decision-making as well. So, we've learned here recently, over time, that the risk of sudden cardiac death, again, is not as high as we once thought in this group of patients, but still a real risk. And our toolkit has gotten more and more fancy through the years in terms of our ability to predict the risk of cardiac arrest. But then you'll get these cases every now and then that just really humble you and remind you how little we really do know and how we're not as good at predicting this as we think. So this is a patient I saw back in 2020 that came to see me. That was really quite instructive. So he's a 50-year-old male, very healthy. He's actually a physician that has a family history of hypertrophic cardiomyopathy in his mother and his sister. And he had been undergoing screening for years at an outside institution and had multiple prior normal echocardiograms. Well, back in May of 2020, he was sitting in his living room and suffered cardiac arrest in his home. Luckily, his wife knew CPR and performed it, and he was resuscitated. His presenting rhythm was ventricular fibrillation. This was his EKG at the time after he was, defibrillated. Normal, very normal looking EKG. This was not the echo. This is the echo we did. He was actually brought to an outside facility for his initial evaluation and then saw us afterward. This was the echo we did on him, which shows preserved LV systolic function, really normal wall thickness, nothing really out of the ordinary on his echocardiogram, including his strain numbers. You see a little patchy variation in his strain numbers, but his overall strain, negative 19.6, comes out as really quite normal. Again, as it is LV wall thickness. So he had a normal echocardiogram. He underwent coronary angiography, which was normal. He had a cardiac MRI, which showed normal wall thickness, no delayed enhancement, normal RV, et cetera. So we did genetic testing on him, and it did reveal a pathogenic variant in MYB, in the myosin binding protein 3 gene, which is the same one that his sister and presumably his mother, who has not undergone genetic testing, but presumably the same mutation that we know his sister has and we presume his mother has. So really a very scary case of a genotype positive but phenotype negative patient having cardiac arrest with no other identifiable cause. By the way, his labs were normal. I showed you his EKGs, QT's normal, et cetera. So there's no real other identifiable cause other than this genotype positive for hypertrophic cardiomyopathy. So, this case, besides just being terrifying, was also underscores the inherent unpredictability of this disease. Sort of the more you know, the less you know, sort of thing with this disease, and it also underscores this concept that we're moving away from this the concept, and we probably need to and are, the concept of genotype positive, phenotype negative. This group of patients that we know carry the gene but have normal imaging. And instead of thinking them as phenotype negative, we think of them as subclinical hypertrophic cardiomyopathy, because clearly this gentleman has some, microscopic disease going on in his myocardium that almost certainly triggered this, malignant ventricular arrhythmia that he has. So we're moving away from this binary of phenotype positive, phenotype negative to, if you have the gene, you have hypertrophic cardiomyopathy, but it's subclinical and we'll treat you as such. So maybe, potentially direct myosin inhibitor as a potential treatment and way to alter the phenotype moving forward, and maybe more close follow-up for these patients as we move forward. And again, underscores the point that we still have plenty to learn about this condition. So in summary, the direct myosin inhibitor mavacamten, not yet approved, but hopefully being approved soon, appears to be a more effective means of treating patients with symptomatic obstructive hypertrophic cardiomyopathy than our currently available medical therapy, and offers promise maybe in terms of even altering the phenotype of this disease, which is something we've really never been able to do before, and hopefully provides an effective means of treating non-obstructive patients as well. It mechanistically would make sense. I mentioned in that earlier slide that it does seem to improve diastolic function in these patients. It lessens wall thickness. It reduces biomarkers. So there's no reason to think that this treatment might not be effective for non-obstructive patients as well. The early experience at our institution with the Sesame procedure has been very favorable. It seems to be relatively safe and effective at reducing left ventricular outflow tract obstruction, and will hopefully provide another treatment modality for these patients with symptomatic obstructive hypertrophic cardiomyopathy, essentially those maybe with unfavorable coronary anatomy for alcohol, that are too high risk for surgery and have unfavorable coronary anatomy for alcohol septal ablation, like occluded LAD or a stent in their proximal LAD that's, making it difficult to access septal perforators, or unfavorable septal perforator anatomy, et cetera. Or sometimes we'll have patients with occluded other vessels with collateral flow from the septal perforators to the inferior wall, for example, that we obviously don't want to inject alcohol and infarct the inferior wall. So this may be another option for those patients that aren't good candidates for alcohol septal ablation. And our understanding for the risk of sudden cardiac death in this disease continues to evolve, but obviously is still imperfect, as that case demonstrates. So I want to acknowledge some folks. I want to thank the structural team, particularly Dr. Bablieros, Dr. Greenbaum, Dr. Incy, and the rest of the team for sharing their data and some of their images, and some of their slides regarding the Sesame procedure, and highlight them again for the hard work they've done in developing this potentially new procedure. I want to thank Aslam for loaning me some of her slides on mavacamten and helping take care of this very interesting group of patients and the rest of the Emory Hypertrophic Cardiomyopathy team, including our excellent surgeons, Dr. Guyton and Dr. Attia, who do our surgical myectomies and do a fantastic job. Really all of our electrophysiology colleagues at all the sites, not just here at Clifton, but at Midtown and at St. Joe's and even at Grady and VA, where our patients show up from time to time, and David and Heather take care of them as well. And our interventional team, Dr. Douglas and others that perform the alcohol septal ablations on our patients. So it takes a whole bunch, and our heart failure colleagues that we refer these patients to, and their ejection fraction drops, our pediatric colleagues, et cetera. And so it goes on and on. It takes a bunch of folks to take care of these patients. I want to salute all of them. So with that, I thank you for your attention and welcome any questions you may have. I guess we can again start with Dr. Balk's question. If we want to refer someone for Sesame, who in the structural team will I refer to? Yeah, Dr. Babalieros or Dr. Greenbaum. Again, still very much experimental procedure, not indicated or not approved, I would presume by, certainly by the FDA, but certainly a good option for those who may not have other options. So question from Dr. Taylor. In the mavacamten data that you presented, the subgroup analysis looked like patients on beta blockers did not have a significant response in terms of the primary endpoint. As this can be considered current standard of care, does this diminish our enthusiasm for this medication? Yeah, that's a good point. I don't know. Also, how did beta blocker use impact efficacy of mavacamten in the biomarker and echo data? Yeah, good, very good question. And yeah, whether this becomes something that replaces beta blocker therapy, I think obviously more data is required to sort of tease that out. I can go back to that slide. Possibly. He's referring to the subgroup analysis here. Yeah, actually, those on beta blockers showed a non-significant improvement in symptoms. They did not do subgroup analyses on the biomarker or gradient stuff. So, right. So I guess as time goes on, that will be something that we'll need to tease out, whether this becomes, and you know, as you can see, it was a pretty decent number, 30% of those on mavacamten were already on beta blockers. So, whether this, as we gather more data, whether this moves to the right and becomes significant or remains non-significant remains to be seen, whether this shows that mavacamten somehow and beta blockers together don't work as well and mavacamten replaces beta blockers. I don't know. Good question.
We have a question from Dr. Mavramatis. In patients who are symptomatic, what data do we have that ablation or myomectomy is prognosis altering?
Yeah, so we do. We do have very good data in terms of heart failure and atrial arrhythmias. Patients definitely their progression to symptomatic heart failure or even LV dysfunction is less after myectomy. They have somewhat lower rates of atrial arrhythmias as well. The main benefit, obviously, is symptomatic improvement. There was one study done at the Mayo Clinic that did show a reduction in cardiac arrest, which is probably what the European calculator is using for placing LVOT obstruction in there. But other subsequent studies have not shown that septal reduction, specifically surgical myectomy, reduces the risk of cardiac arrest. Yeah, I mean, clearly the septal reduction therapy, be it surgery or alcohol, septal reduction improves symptoms, reduces the risk of progression towards heart failure over time in patients with obstruction. So yeah, there's very good data to support that, but not necessarily in terms of reducing death other than one study. So options for genetic testing for uninsured patients. Yeah, so good question. There are a lot of these companies will offer programs for uninsured patients. I know in Oslam, if you're out there and you want to chime in, I believe it's Invitae frequently has a program that they will offer to uninsured patients. And but yes, the Modalay, we can certainly talk more offline, but it's sort of like the drug companies. It's sort of the offers sort of come and go from time to time as to when they'll do it and how they'll do it. But there are potential options for genetic testing for uninsured patients.
Dr. Smith has a question.
Yeah, Robbie, for inherited diseases where there's a single gene defect, in vitro fertilization with pre-implant genetic testing can be done to prevent transfer of that to children. Is that something that we should routinely be thinking about in some of these patients?
Yeah, I mean, it's something that I'll discuss with patients that are thinking about having children. It can be an expensive proposition for folks. I know it entails for some folks it can entail significant out-of-pocket costs, but certainly something that a lot of patients should at least explore their options, particularly in those families that seem to have a really malignant course, whether it's rapid progression to heart failure and sort of the end stages of the disease, or multiple family members that have had cardiac arrest at a young age. I think something like that really makes a lot more sense. And, I thought about actually having a section. I'd even for a little while had we were going to do a few slides on gene therapy for this disease, but it's really still very early, and the slides would have essentially said gene therapy is probably coming someday, but it's still a little ways off. Igioma says, I believe Emory Genetics also has a similar testing options. Yes, for patients with limited income. Yeah, again, most of these companies, Invitae, Emory, GeneDx, they do offer programs from time to time. So it's more just, I usually reach out to the reps from time to time to see what they've got. And they'll usually work with the patients directly on either setting up some sort of payment plan or, making it free or near free for the patients. So Pooja asked, women tend to have smaller, more hyperdynamic LVs. Is there a different cutoff for the 30 millimeter wall thickness for women? Yeah, good point. No, it's the same cutoff regardless of gender at this point in time. Yeah, Oslam confirmed that yes, Invitae has a sponsored free test, a saliva kit that patients with limited income. So anyone wants to reach out to Oslam or we can put you in touch, usually with the reps for the companies, and they can provide you with kits and give you the parameters for the free or near free testing. A lot of times they also offer free testing for the family members. If the index patient can pay, then the family members are oftentimes free as well. So Dr. Smith wants to remind everybody that Alana is doing presumably internal medicine grand round tomorrow.
Robbie?
Yes.
It's Peter Block. Can I ask
Hey,
a quick question?
Peter.
The The folks that have this diffuse hypertrophic disease without obstruction have always been a particularly difficult problem, particularly if their EKGs are normal and so forth. Short question, has anyone ever looked at the LV biopsies in these folks to see if they have any characteristic abnormalities in their myocardium like you see in the LV outflow tracts of the really bad obstructive patients?
Yeah, sort of. You're talking about sort of small, stiff ventricles without a lot of hypertrophy.
Yeah, that have ejection fractions of 85% and so forth.
Yeah. Yeah, no, you're right. I mean, a lot of these patients may represent sort of, no, I don't think anyone's ever done that study, maybe looking at older patients who either, whether develop sort of a restrictive picture or sort of, like you said, these sort of hyper dynamic small LVs that can be difficult to deal with, particularly in patients with, as you know, aortic stenosis and that sort of thing. They're difficult to treat, difficult to assess, where this represents a variation on the theme of hypertrophic cardiomyopathy or some other infiltrative disease like amyloid or something else. I'm sure someone's looked at that. I don't know the data though off the top of my head though. But yeah, I wouldn't be surprised if a lot of these folks, if we biopsied all of them, a lot of them would have amyloid, or possibly some of them would have hypertrophic cardiomyopathy like changes as well.
Thanks.
Okay, great. It's we're a little past 8:30. If there are no other questions, then we'll go ahead and close. Thank you everyone for joining, and have a wonderful week.
The preceding program is copyrighted by Emory University.